Hi, everyone, and welcome to the Silvates podcast. So the content today will be specific to a certain audience, and it's geared towards clinic tutors at an osteopathic university. So some of this might not be relevant for everybody, but if you're interested, please sit down and enjoy. So I've got three people joining me. I've got Sarah Jane Marshall, I've got Phil Bright, and I've got Marianne Damgaard-Jensen joining me. So thank you all for making the time and doing this.
Hello,
Hi,
everyone.
Hi.
Hello everyone.
So we're going to be talking about mini clinical evaluation exercises. Now, you're all the experts on this, so I want to sort of dive straight in and ask what a Mini-CEX is.
Yeah, I'll come in on that one. I mean, the Mini-CEX has been developed as kind of a structured workplace-based assessment, and it's kind of ideal for getting a snapshot of various aspects of clinical practice, whether it be history taking, physical examination, patient management, and it's kind of, I suppose, been derived out of the VIBA process. So where individuals are seen to be engaging in clinical practice in the actual setting as opposed to simulated setting. The beauty of these types of assessment is it captures a small snapshot of that. And from a student point of view, because it's not following that kind of extended pathway of you're being seen with the patient literally from the point of picking them up in the reception all the way through from case-based history taking through to examination, through to treatment and follow-up, it's just providing a small kind of snapshot within one of those scenarios. So from that point of view, it could be argued to be more student friendly, but gives, because you can capture over a broad breadth of those kind of interventions, it gives a nice opportunity to capture them at many intervals.
Yeah, and the beauty of them also is that they get immediate feedback as well. So they love that to help their learning as well.
And then in the previous Vibers, it used to be one examiner. So by having lots of little snapshots, the assessments actually have greater reliability by having different examiners involved.
Yeah, that's really interesting. And I suppose I'm wondering what the primary purpose of it is.
I think following on from Marianne's comment there, it's really to give the students the opportunity to get a direct feedback on their performance, and with the way the format of the CEX is structured, it's kind of a key indication from a scoring point of view how they have performed, but also it gives an opportunity for more qualitative based feedback so that the assessor can actually, write a quick line of what was done well, where there could be room for improvement, and the areas that the student should perhaps take on board in relation to developing an action plan for areas of improvement that have been suggested to them.
Yeah, anything to add, Sarah Jane or Marianne?
Yeah, no, that yes, it does do that, and it's also with their final exams coming up, which is very clinically based. It gives them an opportunity to get a bit of adrenaline going under a little bit of pressure, to just sort of get an idea of what the larger exam in June with the CCA is like as well.
Yeah. So I think it's obviously got high kind of validity in that they're actually doing what they're going to be doing in clinical life, but also, as Sarah Jane says, that they're preparing for what they're going to be doing in their final exam without taking on the whole thing in one big chunk.
And I think as well, because that validity comes from the point of view that the CEX has been established for use across a variety of disciplines. So I think what it provides for osteopaths, particularly student osteopaths, is that ability to understand how they rate against other clinicians in other areas. There's a very broad base to the use of the Mini-CEX, from anaesthetists, radiologists, chiropractors, interestingly enough. So, and the utility of it as well is that it's been developed and used in other countries. So, for anybody who is intending to perhaps go and practice in New Zealand or Australia, it's widely used there. So a practitioner there who wanted to take on a graduate, if they saw their CEX scores, would be able to really place them in the right context, which I think gives a really broad use for it.
Yeah, that sounds really useful. I suppose I'm thinking about who would conduct the CES.
I think from a point of view of a general setting, it's normally the person closely aligned to managing the clinical intern. If we were looking at it quite broadly, so from our osteopathic context, it would be the clinic tutor directly who have responsibility for that student during a set piece of time.
Yeah. And that's how they're done throughout the BCNO group, and we aim to have actually over the assessments what we do is to have a wide variety of assessors so that they get as much input as possible.
Yeah, and are there any sort of key areas or sort of things that are being assessed?
Yeah, I think from the point of view of the CEX capturing that kind of patient practitioner intervention in the teaching clinics, first and foremost, you're kind of looking at history taking skills. Then we move into the physical examination process and how the communication skills link within that. That's obviously then kind of leading nicely into clinical judgment, because those processes prior to that set up the adoption of clinical judgment. And then overriding that, you've kind of got professionalism issues which are being captured, which also then informs organisation and efficiency within how the process has been conducted, from the point of view of the assessor looking at that practitioner and how they've dealt with that particular patient and the scenario that's being captured at that point.
Yeah, just to add to that, as sort of head of clinical education, Sarah Jane and I kind of ensure that all those areas have been covered for each student, so that there's not a snapshot on the case history the whole time, but we kind of look at that, and also that they are exposed to both returning patients and new patient in these Mini-CEXs.
Because the beauty of it is that because it's a snapshot, you might not have to see all the competencies in one.
Yeah.
And by having the 3 or the 6, we can make sure that that is seen across 6, so that they are seen in each competence, as Marianne says.
Yeah, because I can imagine not everything is going to be seen in the one session, and so how do you sort of account for that?
So as you said, basically we keep an eye on it because we have all the scores for each student, or all the forms. So the students usually take a photo of it, or have it emailed to them or whatever. But we also keep an eye and ensure that there's each student has all the areas assessed basically.
And how long would like a Mini-CEX last for? How long could they expect to be doing this for?
So each Mini-CEX is usually 10 to 20 minutes.
Yeah, and that might be that you might do a couple of minutes on one area, then you might pop out, so it might not all be at the same time. But it's trying to really just work with them as a colleague, really, just popping in, see how they're doing, so that it's not too stressful, but still, as I said before, I think putting a little bit of emphasis on an assessment. So yeah, 10 to 20 minutes, Marianne says, maybe a little bit longer with the new patient and the returning patient, because the new patient session just lasts longer than the returning patient.
Yeah, and Phil, you mentioned earlier sort of it gives the student an opportunity to get a bit more sort of qualitative feedback. What kind of sort of feedback would they be getting in this kind of instance that they can then take away with them?
I think in relation to conditions, so if a patient is presenting with a particular condition, then there's scope for the tutor and the patient themselves to kind of ask questions around that, and how the student practitioner deals with that is a really good kind of developmental process for them to go on. And initial stages, they may struggle to recall the information, they may get confused signals, and as they progress through that process, what I think the CEX kind of gives the opportunity for is positive steps in the right direction, which what the feedback will be that build on in relation to that. And I think when you look at that in relation to the dynamic between the practitioner, the student, as it were, the patient, and the tutor, they're all going to be kind of involved in that process. And I think being able to provide feedback around that, not only commenting on how the practitioner has dealt with the condition, but also how they've got the information correctly over to the patient to persuade them that the right direction is being managed. They're given confidence that they can proceed and recover. And all those soft skills, that's, I think, where the key feedback can be provided through this process, which is more than just a tick in a box.
Yeah.
And they have criteria as well that we do look at to help enhance that feedback as well. And that feedback criteria is linked to the osteopathic practice standards, which they need to be assessed against to go and graduate. So that we do have some standards as well to help with that feedback. And it helps them, again, for that CCA exam, because the criteria are the same for the CCA as well.
Yeah, just to echo that, what Sarah Jane said. So it doesn't. It's not all about knowledge. It's about anything within the osteopathic practice standards, really. So it could be communication and consent, shared decision making. It could be how they handle their own posture. So the feedback could be in a wide variety of things. It could also be about, we're not particularly disease focused in how we handle conditions. So it's actually about how they can see that personal context for that patient, taking aboard their wishes as well as putting it into the context of their findings, examination findings, when they put the plan together.
Yeah, I think what's really, really good about that process as well is what the form offers is obviously feedback directly to the examiner. So it's a two-way process, and there's very few assessment tools out there that actually allow for that dialogue to take place. Mm-hmm. And I'm not saying it's perfect, because the rating, the relationship between the tutor and the student, for various different reasons may be an issue, but what it still allows is for the student to go, actually, how did I feel during that assessment process? How satisfied was I with the process and the outcome? And I think that's really good at heading off issues around mismanagement and conduct within assessments, because the student has got that direct feedback route to follow on.
Yeah, but maybe not quite clear for when we don't have a visual of the form here, but the qualitative feedback on the back, has kind of areas that are done well, areas for improvement, and then the last box is like a reflective box for the student to fill in. Both about the action plan, but also, as Phil said, kind of feedback on how they felt, time taken, things like this.
Yeah, and you've sort of alluded to some of the challenges in a way of doing these. I wonder if there are any other challenges that you can foresee or have encountered when you've done them.
Yeah, I think one of the kind of common criticisms around it, certainly from the context of use in osteopathy, is that I think concerns have always been raised about, well, how does it capture the kind of osteopathic element? And actually, if you look at it as a totality, the fact that it's being done within the setting is the osteopathic element. That's what we are capturing, what's going on in terms of the process and in terms of the thought behind the way that the person as a patient is being managed. So the osteopathy is implicit. It doesn't have to be kind of rubber stamped on it as this is osteopathic. Because if the students are embodying the concepts that people recognise as being osteopathic, then that will come out within the context of the assessment.
Yeah.
And also the assessor reliability is one area that you need to be aware of. And that's why by having, as Marianne spoke about earlier, up to 6, they show that the reliability and validity is much better. And also with training. So we're hoping that this will help. And then observation of peers, supervision, constant revisiting. And that's something that we've done over a long period of time. And when people come into the role, we make sure that they're ready to start that assessment as well. But that's one area which students are always talking about. Oh, somebody's going to mark me higher than somebody else. And actually, we had a few years ago with a student who was excellent at spreadsheets, much better than myself. And he ended up by helping me with a spreadsheet. And we inputted all the assessor marks, and he said, "Okay, they are across the across the board." A good range for all of them. So training is important.
Yeah, I agree. It's actually about examiners really understanding that it's been shown to be reliable by having numerous snapshots, and it also helps that you can have a bad day on one section and it's not the end of the world. It's because it is this kind of lots of snapshots. So the main problems we've had is where tutors sort of want to be thorough to do it for longer, but that's not really the point. The point is it is a snapshot, and therefore it's not too stressful, as we said, and it's a very specific point where you can feed back to feed forwards, because a small feedback can lead to a very specific actionable point that doesn't lead the student into overwhelm. They can actually tackle something there and then. They get the feedback and they can action it straight away.
Yeah, and I can imagine that you talked about training the clinical tutors, and I imagine that's to, create the standard across everybody's sort of competence and knowing how to deliver it, I can imagine.
Yes.
Yeah. I mean,
and there's enough formative opportunities as well. And I think you kind of look at the formative process as being formative not only for the student but for the tutor as well. And people are finding their feet. Particularly when you've got new students in year 3, and you may have a new tutor. There's that real opportunity to kind of find the happy medium, which you wouldn't necessarily get if it was straight into a summative approach.
Yeah, absolutely.
Yeah.
And I imagine that framework also gives them a bit of structure in a way.
Yeah, and I think as Sarah Jane said, that although the details of the form aren't specific to the OPS are embodied within the elements of it. So I think, in terms of meeting the needs of the regulator, that aspect is quite well covered.
Yeah. And we have marking criteria relating to this as well. Mm-hmm.
Yeah. And I'm wondering how, you talked about sort of giving students feedback. I'm wondering how sort of that feedback is delivered during that sort of Mini-CEX.
Yeah, so the students, once it's completed, the tutor will find a time that as soon after the assessment as possible to sit down with the student and go through areas. Ideally, how do you think it went? So that it's a dialogue between the two, and then going through and then using examples for any feedback that they have. Ask the student to reflect on that and then devise their own action plans. So it's an immediate feedback. The research, which Phil, I'm sure, will be able to tell me the most recent research on immediate feedback, how valid that is for a learning within assessment, and for the learner. And yeah, that's how it's done. And then with the students, we can either input it and it goes into a centralized sheet, which, as Marianne was saying, that gives us an opportunity to look at all the categories, what may have been covered in one assessment, to make sure they're covered in another one. And we ask them to screenshot it as well, so that they've got an immediate record of it for their own use as well. So they may have time to reflect after the exam, maybe an hour or even a day or a week later, rather than immediate, because things can change slightly after the immediate feedback, I think.
Yeah, it's an interesting point, because I think even the satisfaction scores from the students and the assessors as to how well the assessment process has gone are reflexive in that it's literally an immediate response and scoring that they're providing. And one of the challenges within that is all well and good if you've done really well, but if you haven't done so well, there's kind of a de-escalation needed within that process. And sometimes I think it's a case of, right, okay, here's the feedback, you've got a copy of it, you may not have enjoyed the assessment as much as the other ones where you got maybe a really good score, but go away, reflect on it, and then we can come back and talk about it after. But I think, in some instances, some of that immediate feedback could be really, really highly warranted. If we were seeing instances where there was particular potential for unsafe practice, if there was a particular issue around patient handling that had to be managed, it's putting, in a way, the patient at the heart of that process, so you can get that feedback to say, this is what you need to avoid because it's not right for the patients, it doesn't fit the OPS, and ultimately, you're directing that student to avoid potential issues when they're in practice on their own.
Yeah.
Yeah, and Marianne, you sort of talked about some of the marking criteria earlier. I wonder if you can talk a little bit about how it's scored, for example.
So it can be scored with a Likert scale, but it can be scored in any kind of banding, and obviously ours has to be fitting in with a Plymouth banding scale for level 6. So that's what we've mapped it out with, and then we've got the various areas that we look at. So case history taking, clinical reasoning, physical examination, working diagnosis, and then prognosis and treatment, and lastly consent and shared decision making. So we've got like 6 areas that we look at, and I said we make sure that all those 6 areas are covered by our assessments, and then the criteria is based on the Plymouth scale for level 6.
Yeah.
Within that as well, if you look at the kind of wider utility of the Mini-CEX, there's been many ways adopted in terms of scoring the process, all the way from, kind of extended scales that have gone from kind of 1 to 9 on a performance rating to pass-fail, where, one individual, would perhaps assess in terms of is somebody clinically competent or not. But it does depend on kind of requirements around the final degree classification, and so that will have an impact on how those scales are contrived to a certain extent. So, if anyone was to come forward and go, oh, so what, I've looked in the literature of this and I've seen that, radiologists are just pass-fail, or, the anaesthetists have got this massive 9-point scale and, they all do really well on it. It's like, well, yeah, but part of that's because that's based on the requirements for their profession, and part of it's probably based on the requirements for the validator that's approving the degree, and it's horses for courses. So you have to appreciate why this has been said in such a way for use of osteopaths.
Yeah, and it sounds like you've really sort of taken the time to sort of take sort of a model and really apply it in its true sense to make it relevant.
Yeah, I mean, if you look at, so, in a way, osteopathy has been probably a little bit of a groundbreaker in this area, because I think we're looking at now heading into kind of 10 years plus of use of the CEX within the profession, both here and internationally, and there's very few opportunities where you can kind of celebrate that kind of level of involvement and, in a way, cross-pollination. So, looking at that in terms of what it relates to in relation to practice in Australia and New Zealand, and how we can kind of look at that as a context for our own practice in the UK. It'll be interesting to see how it's kind of extended into the European area as well. Perhaps from an international point of view, that could be something that the BCNO group could pick up and see how well that would translate over to our European partners.
And if you have someone who's sort of never conducted the CEX before, sort of where would they start? What would you recommend?
From a research point of view, I would say have a look at the work of Brett Vaughan, who his PhD was all around clinical assessment and management within teaching clinics and osteopathy, but Australian based. But I think it would be useful for a start point, because you get to see the differences between programs between countries. So Australia run a 5-year program, believe it or not. Here we are in the UK talking about condensing programs, and they're really trying to get their money's worth out of the process. And probably if they could get the students into 6 years, they'd be up for that as well. But it's interesting because when you look at the results that Brett reported, you start to see how you spread more thinly, in a way, the outcomes from the CEX. So, there's a marked difference in terms of transition between the levels that we have between, say, year 3 and 4, when they're going year 3, 4, 5, and 6, as it were. There's a very long drawn out process within that. So maybe that does support a better argument for condensed programs, but we could spend another podcast on that one.
And I think Phil's right. So I think understanding the concept of the assessment is really important. So directing them in it is really good. And then, when you get once they've got the understanding, is explaining where it fits into the program. And then it comes down to training and practice. And as Phil said earlier about the formative opportunities, you can go and do it anytime.
Yeah.
And then quite often what we'll do with tutors is get them to watch somebody do one. So we just have people watching them, and then they do it themselves. And it's good practice for the students because it doesn't go anywhere. It gives them feedback immediately, which they love because it's centered on them for a period of time as well. So that there's plenty of opportunities. And then what we do is only when somebody feels comfortable, and taking that on for a summative assessment. And then what we'll do is myself and or Marianne may observe them in practice to make sure that they're comfortable with it. And so it's training on the job, really, as well as making sure they've got the understanding of the background of what the CEX is trying to achieve.
And I think, as Sarah Jane said before, I think it lends itself really well as an assessment to prepare them for the FCC, because we've had a lot of trouble in the past at that level 6 prior to the FCC of trying to, so that's generally third year as in the current model, of having assessment that really have high reliability. And I think this one here, has the benefits of higher reliability than most of the other assessments that institutions have been doing before at level 6. And then also better feedback to feed forwards because there's lots of bits to it, so it's not just this one exam, it's lots of bits. So whilst one assessment doesn't cover everything, it covers something actionable. And I think in this time of tendency to overwhelm and too much information, I think it fills a really good gap there to allow students to action something definite and feel that they can improve something quite particular. And as Phil said as well, also capture something that might be potentially dangerous or save the student, handling in a way that's going to damage them or whatever, so it has a lot of potential in that way.
And also, it's because it's freely kind of available, and the processes and the forms that underpin it are shared quite readily amongst the kind of learning resources. The students can assess each other with it. It's a case of, if they were doing an observation, put yourselves in the role of an assessor and see how you would apply the criteria. And that, I think, is really useful in terms of not only kind of the simulated aspect of it, but also the fact that they start to appreciate what assessors will be looking for. You can't necessarily do that with an FCCA because of the length and the time of it and everything else. But something like this, which gives you that small snapshot opportunity, is ideal.
Yeah, we use that throughout the BCNO group with peer assessment and encourage that all the time. And I think, as you said, Phil, it's really helpful. I think in days gone by, they've had really the wrong idea about what we're trying to assess, and they don't realize that the processes that we're looking for, they think we're sort of world championship in finding the right diagnosis, which there's no such a thing, of course, in osteopathy. There can be many truths, depending on which lens you look through.
Yeah, and as you said earlier, Sarah Jane, it can be used as both a formative and a summative type of assessment. I'm wondering how often they can be used.
Well, as Marianne was just saying, anytime they like. So we do like an official, if you like, formative, so that they all at least understand what the process is like. And I think quite often with a lot of assessments, it is all about process and the understanding of it. And once they get an understanding of how it works, it's a bit less scary the next time. And the next time and the next time. And as Marianne says, if they can take those forms anytime, practice anytime they like, they can complete them online so that they can actually go onto the spreadsheet. We can give them a copy of that. They can take their own copy if they want to do it. It's in written form as well, so it's not in printed out form. So yeah, anytime they like, to be honest, I would say that they don't use it as much as they could use it. But it is there as a tool. Anytime they like, they can go and grab a form from reception area.
There's even potential that you could, use it as a patient feedback process as well. So, somewhere down the line, it would be like, with a patient after the process of their consultation and treatment, it would be like, okay, using this criteria, how would you rate that element of your treatment? So the utility of it is pretty wide.
Yeah,
that sounds quite novel and quite interesting, actually, to be using it from a patient perspective. I imagine that'd be quite interesting. I'm wondering if there are any best practices to implementing the Mini-CEX.
I'll lead on that one. I think we've kind of looked at the elements around it, I think, in some of our previous kind of responses, but part of this process is trying to get the evaluators engaged and thinking curiously, I think, about how best to apply the use of the examination tool. The beauty of it is that, with these types of resources and with what's available on the Moodle learning platform, there is guidance, there's structure, there's always that open dialogue between the students and the tutors, and the tutors and the clinical staff. So I think that's really, really helpful. Probably, for you guys, the biggest issue is probably scheduling. You might like more assessments, you might like less assessments, but overall, you've always got to kind of appeal to the wider sensibilities of the university and the regulations around that. So you could be caught between a rock and a hard place where that's concerned.
Yeah, it's been challenging. We ended up, but with the new program, the year threes, to get the reliability, and we do 3 over a sort of a month period, and to get all of those in with the students is quite full on, quite busy. And the admin staff have been absolutely amazing in the clinic reception areas to facilitate that. So it's almost come, I think the students, again, it's become a bit more natural rather than so much pressure, that they've got that opportunity. And as Phil was saying, that if they have done not so great in one, they've got almost an immediate opportunity to pick themselves up again and reflect. So yes, it is a challenge administratively, but seems to have gone well, to be honest, with the first lot gone through.
Yeah, definitely an administrative challenge, but I think, again, really big praise to the admin staff in London as well, and I think we have slightly less trained examiners, and we're getting a few help from Kent this time, because we ran slightly over by a week and a half to get them all in. Over the time we'd sort of aim to get them in, I think it's an administrative, but I totally agree with Sarah Jane. I think the students really normalized in terms of the pressure of having somebody assessing them, understood what it was about over the 3, and had this feeling of each time it was feeding forwards, and each time they had another chance to demonstrate, and they got more and more understanding about it as we went along. And obviously we started, as Sarah Jane said, with formatives as well.
Yeah, I think when we looked at the kind of profile of grades over a couple of years as a research piece, this was a few years back, we did see a nice kind of linear increase from those initial kind of formative developmental assessments through to their kind of final year assessments. So sometimes we just expect that, and we kind of think well, that's what we hope to see, but it's nice to be able to have something that does reinforce that evidence. And I think, particularly from a student point of view, if you are able to see that progression in real terms, ultimately as well, what I think what's good about it is that, the good students who achieve the good grades, they still haven't necessarily started off with the top grade in the assessment, but they progress to it. But overall, their grade profile is so good that it contributes to that kind of final good degree classification. And even if there's a little dip in there, overall it's the consistency and the fact that we're able to provide these assessments on so many opportunities that gives the good students the opportunities to build that strong grade profile. So, I think it's much better than that kind of, one shot captures all. And if you miss that opportunity, you're kind of sunk. It's really helpful for the developmental side of things.
I think this has been a really interesting and valuable sort of opportunity to learn about what the Mini-CEX is, because I think even as staff members, sometimes we're not aware of sort of some of the developments and even the reasoning behind them. Sometimes it can be often, oh, there's a new thing to have to implement and there can be some resistance. So I'm really hoping this will provide some staff members and students as well as into a bit of an insight about why we do this and what it really is.
Yeah, that's great. Thank you, Sylvain. I think the other thing as well to just to mention with that is that initial rounds when we went through the developmental side of this was done with kind of complete consultation when it was first brought in Kent. So, I think winning the hearts and minds and bringing people on board from the start of those types of changes is absolutely vital.
Yeah, I absolutely agree.
I agree with that. So thank you very much in helping with that process by providing this platform for informing everyone about the Mini-CEX.
Yes, thank you.
Yeah, thanks, Sylvain.
Thanks, everyone.